Hi, this is Andrew Phillips, the editor-in-chief of EM Coach. This month's question, if you haven't looked at it, please do. We're going to be talking about the answers, a spoiler alert. This month's question is a very good example of an exercise of strategies for taking questions. The key to getting this one right not only is recognizing the fat embolism syndrome with the femur fracture recently and coming in with shortness of breath, but also recognizing that the question is asking for the best next step. So basically the patient has had a femur fracture. We're presuming that it was pinned, and what we're seeing now is the original x-ray from presentation. Comes from a sniff with shortness of breath, and you're seeing basically an ARDS type pattern with bilateral opacities in the lungs. And you can see an ARDS type pattern with fat embolism syndrome. It's worth pointing out that fat embolism can occur in multiple places. You can have strokes with it. You can go in the lungs. It can go to some of the viscera in the gut. You can go anywhere. But certainly the lungs are one of the more common places that you'll see this. Now, when you're looking at it, something I wanted to fill in was that the CT scan, you can have various findings. A lot of times what you're going to see, at least it's reported in the literature, is various locations of like nodules that have some opacities to them that are spread throughout. You can also sometimes see some filling defects, but oftentimes these emboli are going to be so small, you're not actually going to see a filling defect of great size. What you're going to be seeing is those nodular opacities that are a reaction to the fat. And this is going to have a different appearance than a typical picture that you'll have with regular ARDS, but that initial set of nodules can then develop into an ARDS type pattern. So back to this question. First of all, when you're looking at TPA and heparin, if it's a fat embolism, which you can do, for example, looking for fat in the urine to help establish this diagnosis, because pulmonary embolism and associated DVT certainly needs to be behind the list. But if you're leaning more towards the diagnosis and have a diagnosis of fat embolism, then you're not going to heparinize this. You're not going to use TPA. You have to resist that feeling that you have to do something for it, because all those thinners or thrombolytics are going to do is make things potentially worse. They're not going to help the actual fat embolism. So leave that part alone. The next question is whether you should be applying positive pressure ventilation. And that's where the crux of this comes in, right? So some of the things that are not options on this particular test test question are if you should be getting the urine, looking for fat, if you should be getting a CTPE. It's asking for the best next step in management. And in that case, this patient is, although setting 97%, it's on a non-rebreather. And patients, whether you're talking about fat embolism syndrome and having bilateral opacities or a more typical ARDS picture, they're losing surfactant. That's part of the pathophysiology of the process, and they need that positive pressure, whether it be non-invasive or invasive positive pressure. Now, in this patient, and generally speaking, a trial of non-invasive positive pressure is usually warranted, and so that's what makes this the best next step in management, is to address the airway, right? Always A, B, C. And so that's why you want to be addressing that first. Setting 97%, but thinking ahead and where things are going, and the pathophysiology of fat embolism syndrome makes really the proper care for this patient the best next step, thinking ahead to try to get off that non-rebreather and go ahead and put on some non-invasive positive pressure ventilation. So that's fat embolism syndrome for you. This is Andrew Phillips from EM Coach. Thank you for watching.